Good afternoon and welcome to this afternoon's keynote session. My name is Dr. Sarah Alderson and I'm a GP and Associate Professor at the University of Leeds. I am very pleased to introduce our first keynote speaker of this session, Dr. Kaveh Shojania, Professor and Vice Chair of Quality and Innovation at the University of Toronto. Dr. Shojania's research has focused on identifying and developing effective strategies for achieving improved healthcare quality. He has published over 150 highly cited papers and helped shape publishing related to healthcare quality through his work as Editor-in-Chief at BMJ Quality and Safety. Under his care, the journal now has one of the highest impact factors amongst journals covering not just healthcare quality and safety, but also all of health services research. There is continuous pressure to improve healthcare quality and safety, which often leads to conflict between the pragmatic need to do something and undertaking rigorous evaluations to work out what works. Today, Dr. Shojania will be talking to us about the tension between needing to improve care and knowing how to do it. I'd just like to remind you that there's a question and answer live tab on the right-hand side of your screen. Please put any questions in there for us to get to at the Q&A session following the presentation. Please welcome Dr. Kaveh Shojania.
Thank you very much for inviting me to be part of your conference. I'd originally planned to talk about the tension between needing to improve care and knowing how to do it. But when I saw the theme of the conference, Living and Dying Well, I felt that I would focus instead on the need for our healthcare improvement efforts to target the social determinants of health and collaborate more with people working in other social care sectors, such as housing, schools, and the criminal justice system, among others. I believe we need to target our improvement efforts in this way if we are to have any chance of meeting the challenges of the massive crises we face, crises which will exert both direct and indirect effects on health at a scale we've only had a taste of during the past 16 months of COVID. I think we all have an idea of what these crises are, but just to be clear, they include not just the current COVID pandemic, but the near certainty of future pandemics, the climate crisis and collapsing ecosystems, systemic racism, levels of economic inequalities approaching those last seen under feudalism, and the ongoing opiates crisis, which in parts of the US and Canada lowered average life expectancy even before COVID did so. These crises will worsen already existing disparities in health within cities and across countries. Here is a particularly striking depiction of these already existing disparities in basic health outcomes, even across neighborhoods within a city. As most of you will undoubtedly recognize, this is the London Tube map, but with the surrounding neighborhood, the lifespan in the surrounding neighborhood shown for each station. As you can see, there are areas with very long lifespans, for instance, 90 and 96 years along the red line, and then the next stations drop to 85 and then 79 years. It's hard to think of biomedical interventions with a 17-year difference in lifespan, other than public health and living standards, the things we have watched be eroded over the past 75 years while we have pursued an agenda dominated by precision medicine. It's also hard to see how increasing the uptake of the recommendations in clinical practice guidelines will mitigate these gaping disparities in lifespan. Why am I so pessimistic about improving our way out of these problems? Because most improvement interventions don't work or produce marginal gains. Over 25 years ago, a systematic review of interventions to improve professional practice concluded that we have, quote, no magic bullets. Most interventions achieved small to modest improvements in recommended practices. The points on this slide summarize the main results of 3 more recent meta-analyses evaluating common improvement interventions, including computerized decision support, audit and feedback, and educational outreach. I chose these 3 examples partly because they represent common approaches to improvement and partly because all 3 of these meta-analyses reported their results in terms of the absolute improvements in recommended practices. They did that by capturing the percentage of patients receiving recommended care or not receiving inappropriate care. To appreciate why this result is so disappointing, I'll use the results from the most recent of these 3 meta-analyses, which came out just this past September. Across 122 trials, a median of 39% of control patients already received what was being recommended by the decision support intervention. The meta-analytic result means that the typical percentage percentage in the intervention group was 45%, which is to say that just over half of patients still did not receive recommended care. So the typical result confers really a drop in the bucket. Here's an example of a cornerstone of clinical care, namely statins to lower lipids. Among patients with established atherosclerotic cardiovascular disease, 33 to 100 patients need to take a statin for 10 years in order to prevent one cardiovascular death, MI, ischemic stroke, or recurrent ischemic event. The second bullet point highlights the trivially small impact on longevity, 10 days in primary prevention trials and 17 days in secondary prevention. Imagine if instead of a vaccine for COVID, we spent billions of dollars a year on a medication that 33 to 100 patients need to take for 10 years in order to prevent one COVID-related hospitalization or death. We are so used to seeing the therapeutic effects of our interventions reported in terms of odds ratios and relative risks, often for disease-specific endpoints, that we forget the rarity of medical interventions that materially improve the length and quality of people's lives. The Canadian Medical Association produced this graphic a few years ago. While one may quibble with the specific percentages assigned to each category, I think it's hard to argue with the qualitative picture that most biomedical research and healthcare delivery does not match the major causes of poor health. Some of you may be familiar with the books Switch and Made to Stick by the brothers Chip and Dan Heath, management professors at Stanford and Duke, respectively. Dan Heath's latest book, Upstream, focuses on the problem of making reactive changes as we do in healthcare, rather than preventing problems before they arise. As he writes, the US healthcare system is designed almost exclusively for reaction. It functions like a giant undo button, but it's hard to find someone in the system whose job it is to ask the question, how do we make you healthier? The book includes a number of substantive and inspiring examples of the hard work of tackling complex problems with direct and indirect effects on people's health. The context for this particular example is that among racialized young men in Chicago, homicide claims more lives than the next 9 leading causes of death combined. Over about a 10-year period, a nonprofit group working with the University of Chicago's crime lab developed and iteratively refined an intervention that has now been shown in 2 randomized controlled trials to produce statistically significant reductions in violent crimes and significant increases in high school graduation. Another example of upstream success Heath mentioned in his book is what is called housing first. Rather than making housing conditional on abstaining from substance abuse, getting a job, or achieving other bureaucratic milestones, people are given housing first and then have the stability and cognitive bandwidth to tackle the other issues in their lives. The examples Heath discusses are US examples, and I couldn't find trials for them, but this Canadian example was reported in JAMA and uses the same philosophy, evaluating the intervention in a patient-level randomized control trial in 4 cities. The intervention group received rent supplements so they could live in regular apartment buildings, not buildings with large concentrations of formerly homeless people, and they also received case management for their mental health and addiction issues. As you'll see, each city showed a substantial absolute increase in the days stably housed. There were no significant improvements in quality of life, but it's easier to imagine this intervention being iteratively refined to achieve that goal than it is to see how getting more healthcare or inventing new medicines will achieve that goal. The bottom line I've concluded is that targeting narrow aspects of specific conditions or aspects of healthcare delivery has generally produced marginal benefits, which are dwarfed by the massive impacts of socioeconomic factors. We need to tackle problems with concrete impacts on health, not just healthcare, and collaborate with partners in other social sectors as we do so. These sorts of projects require the right sort of team, and they take time. But people tend to overestimate what they can accomplish in 1 year, yet underestimate what they can achieve in 5 to 10 years. As I've started to collaborate with people working on these sorts of issues, I've thought of this quote often. Some of you may have heard it attributed to Bill Gates, but it was actually anonymously quoted even in the computer science community, even back in the 1960s. But Gates certainly deserves credit for popularizing it because whoever said it was onto something. The hope that quote brings was brought home to me a few months ago when I read this extraordinary book, The Ministry for the Future. The author, Kim Stanley Robinson, won basically every important science fiction award for his trilogy, the Mars trilogy. Yet this is not that sort of science fiction. It takes place now and over the next 30 years. It opens with horrific depictions of how bad things will be, including a heat wave in India killing 20 million people. But then plausibly and inspiringly, it depicts the ways that different people and groups around the world make necessary changes to various aspects of society. The action spans the globe with popular uprisings, eco-terrorism and asymmetrical warfare, student debt strikes, and geoengineering. Green New Deal style programs in a number of the world's largest economies feature prominently, with the post-BJP India leading the way. One terrific aspect of the book is the way it intelligently deals with the problems of massive financial inequality and the ideologies of racism and cultural displacement, which have contributed to so many of the massive crises we face, not just the climate crisis. And on that note, that so many of the massive crises we face ultimately have to do with questions of equity and othering and the ongoing application of outdated policies and ideologies, I thought I'd end with this passage from a recent essay in the Financial Times by the novelist and activist Arundhati Roy. Historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our data bank and dead ideas, our dead rivers and smoky skies behind us. Or we can walk through lightly with little luggage, ready to imagine another world and ready to fight for it. And with that, I'll say thank you for your attention, and I'm happy to answer any questions.
Thank you so much. That was a fantastic presentation and certainly a lot to think about. Just want to remind people that you can put questions for Dr. Kaveh Shojania in the box on the right-hand side. We'd be happy to answer some questions. We've got a few minutes for that now. So to start things off, as someone who works in looking at improvement science and in trying to improve quality of healthcare, particularly using audit and feedback, from your presentation, would you say that it's important that we still work on trying to improve the effectiveness of these methods to improve quality of healthcare, or should we really be focusing now on these determinants of health?
Thanks, Sarah. Well, I still work in quality improvement too, so I'm not going to say it's not important, but I think no matter how well we ever got any of these interventions to work, audit and feedback, computerized decision support, whatever you want, the reality is we would never be able to do more than a handful of targets at the same time. You can't possibly inundate people with report cards for all of the problems that we have, and same with computerized decision support, alert fatigue, that sort of thing. So I think the reality is that we have to be very careful about our targets and choose them wisely, because we know it requires a lot of effort to implement things successfully, and so it better be worth it. The effect size of the original thing that we're trying to improve better be worth it, and our implementation intervention better be worth it too.
Great, thank you. And so earlier on in this primary care research conference, we heard from Tony Aveyard, who was talking about primary prevention in primary care and how GPs are quite unwilling to take this on and provide sort of primary preventative motivational interviewing and things like that. How do you see the role of primary care within sort of addressing these inequalities?
Oh, well, obviously, I think the potential is huge, but at the same time, we can't dump all these problems on poor GPs. I mean, one of the problems in that book Upstream that I mentioned, he gives 3 reasons why we haven't done more of this. But one of them I'll mention is directly relevant, Sarah, is that under the current system, it's sort of optional to tackle all these upstream problems. It's not optional, for instance, to take care of somebody who's obese and has their diabetes now or their sleep apnea, but it's optional to prevent obesity in the first place, so it never gets done. But anyway, primary care for sure has a huge role, but we need to restructure a lot of other things to make it feasible for them to do that. And I think we have a question that you wanted from the audience.
Yes, so Adam Harvey Sullivan says, thank you for your powerful presentation. What is the boundary between primary care and public health? And similarly, the boundary between healthcare and politics, and how do we navigate these liminal spaces?
Oh, I wish I could say that I had an answer to that, but I guess I would say that I don't know. I mean, it's different in every country. Maybe I know that the NHS has had all kinds of cuts and financial problems. I mean, all countries that's true. But we do have a lot of the money compared to a lot of other social services, at least in Canada, the United States, and I still think in England. And so I don't know the answer for exactly how we need to make these things happen. And I guess, but clearly they're a priority. And the purpose of my talk was just to draw attention to the need to work these things out. It'd be ridiculous for me to think that I had the answer to all these like massive problems. But I definitely think primary care and public health need to have more collaboration, and we need to do more to enable that.
Great, thank you very much. We've come to the end of our time for the Q&A session now, but just a reminder, you can connect in the hub or email and ask any questions that are still remaining. Thank you ever so much.
Thank you. Take care, everybody.
Hello, I'm Lucy Ziegler. I'm an Associate Professor in Palliative Care at the University of Leeds, and I'm absolutely delighted to introduce Professor Katherine Sleeman today. Professor Sleeman is the Lang-Galaska Chair in Palliative Care at Cicely Saunders Institute, London, and at King's College London. And the relevance of palliative care to primary care has never been greater than it has been over the last year, where we have seen home deaths increase by 43% during the pandemic. Professor Sleeman's world-renowned research focuses on meeting the palliative care needs of people with dementia, and she uses large data sets to explore trends in palliative care access. Her work also focuses on the intersection between palliative care and policy, and today Professor Sleeman will talk to us about end-of-life care, bridging the evidence policy gap. Please do use the question function to ask questions, and we'll revisit those at the end of the session.
Hello, my name's Katherine Sleeman. I'm a clinical academic in palliative medicine based at the Cicely Saunders at King's, and I'm really delighted to be here to talk about end-of-life care, bridging the evidence policy gap. So we know that the demographics of dying are changing. We are dying at older ages. By 2040, more than half of all deaths will be at age of 85. And we are dying with greater complexity as we live long enough to accumulate multiple medical conditions. We also know that the number of people who die each year is going up. This is data just for England and Wales, but it looks very similar for Scotland and Northern Ireland. So there are about 500,000 deaths each year in England and Wales. That number is set to increase about 25% over the next 20 years. So what that means is by 2040, there will be an additional 100,000 people dying each year in our society. They'll be dying at older ages, they'll be dying with complexity, and we'll need to take care of them. And what is more, the vast majority of those people who are dying will have palliative care needs. So I'm particularly interested in dementia. We all know that dementia is now the leading cause of death in England and Wales. We know also that among people who are dying with dementia, they have a symptom burden that increases as death approaches and is equivalent to that found in other conditions like, for example, cancer or organ failure. And we also know that the number of people dying with dementia is going up really very quickly indeed. So it's estimated that there will be roughly a 3-fold increase in the number of people dying with dementia between 2020 and 2040. And again, most of them will have palliative care needs. Now, when I say palliative care needs, I don't mean they will need input from specialist palliative care. Actually, for most of these patients, their palliative care needs will be met in primary care and in the community. The question of how our healthcare systems provide the care that's needed to this escalating number of people is an absolutely critical one. And although there are many answers to that question, many kind of facets to the answer, I think that a large part of that solution lies in engaging policymakers with our research. So the title of this talk is around the evidence policy gap. What is it? So we know that good policy happens when 3 things come together: policy, evidence, and delivery. For example, policy and delivery without evidence means that untested interventions are rolled out, potentially causing harm. Evidence and delivery without politics means that interventions that we know work end up not being used and therefore not having the maximum benefit for society. So is there an evidence policy gap in palliative and end-of-life care? We were interested in asking this question, and to answer it, we explored health and wellbeing board strategies in England. So there are 152 health and wellbeing boards in England, and each of them has produced a strategy. So we systematically identified them and searched through them to see what they were saying about palliative and end-of-life care. So the first kind of result is that actually half of them said nothing at all. In a very small number, in about 6 illustrated here in green, palliative care was a kind of strategic priority. But what was perhaps even more striking and more important was that where these strategies recommended interventions for improving palliative and end-of-life care, they were never informed by evidence. So the answer to this question, is there an evidence policy gap in palliative and end-of-life care? I would say firmly yes. So of course, the next question then is, how can we bridge this evidence policy gap? And there are 2 strategies that I want to mention briefly in this talk. First of all, we need to understand political priorities and do research that directly addresses them. And secondly, I think as academics, we need to be better at framing and communicating our evidence so that it's timely, relevant, and easy to use. So I'm just going to tell you about a couple of projects that speak to these aspects here. So first of all, some work which is really led by one of my PhD students called Javiera Leniz. So Javiera is a GP who trained in Chile. She's Chilean, but she's overdoing her PhD with us. And she's interested in the link between primary and community care and secondary care among people dying with dementia. And the first project I want to tell you about really draws together 2 big policy priorities. The first is identification of palliative care needs before death, which we know is a priority through using the QOF. And the second is around secondary care use before death among people who are approaching the end of life, which is a quality indicator used by CCGs to get a sense of the quality of palliative and end-of-life care in local areas. So for the first project that I want to tell you about, Javiera used something called the North West London Whole Systems Integrated Care. Essentially, it's a system which is relatively limited in geography. It's North West London, but it's really rich in terms of the type of data that's included. It includes data from GP practices, from secondary care, and from community healthcare trusts. The data is sucked into a secure data warehouse where she has been able to access it for use in research. So she was interested in asking the question, well, does identification of palliative care needs before death for people with dementia affect subsequent hospitalization? This paper is just published in Palliative Medicine, so please do download it and have a read. There isn't time to tell you about these results in really any detail, so I'll just give you a very brief overview. Essentially, she found about 1/3 of patients who died with dementia did have identification of palliative care needs before death. And she found that for about 20% of the cohort, this identification occurred in advance of the last 90 days of life. Now that's an important line in the sand, because it's the last 90 days of life that these burdensome transitions that are used as a quality indicator occur. She found indeed that patients who had identification of palliative care needs before the last 90 days of life were less likely to have multiple hospital admissions in the last 90 days of life. And to get a sense of what the mechanism underlying that might be, she looked at whether patients who had identification of palliative care needs had other aspects of care that was different. And she found that they did. They were more likely to have more GP contacts, more likely to have community nurse contacts, and more likely to have palliative care team contacts during the last 90 days, indicating potential mechanisms whereby this association between identification of needs and fewer hospital admissions might lie. So of course that data is just Northwest London. What she then went on to do, and this is still preliminary data and unpublished, so not for dissemination, is use a national data set, so the CPRD database, to examine whether the same phenomenon is found looking at national data. And she found indeed it is. So in this study, again, unpublished, not for tweeting, she identified just under 34,000 people who died with dementia. She found indeed that those who had palliative care needs identified via the palliative care QOF were less likely to have multiple admissions in the last 90 days. But what she was also able to do was take it a step further and say, okay, well, which patients are most likely to have that reduction in hospitalizations. And she found several characteristics that were more strongly associated. So people who were most elderly, people who had the least number of comorbidities, and looking here at the bottom, people who lived in care homes, these groups were groups in which this association between being on the palliative care QOF and having reduced number of hospital admissions was strongest. So second, I just want to talk very briefly about how we frame and communicate our evidence so it's timely, relevant, and easy to use. There have been some nice academic studies that have tried to answer this question. A couple of them are here, and they've told us really important things. For example, policymakers, when they are wanting to identify evidence, they don't use PubMed. They use Google. They select information pragmatically rather than systematically, and they're more influenced by conversations and stories than they are by p-values or confidence intervals. This is a nice systematic review. People may well have seen it before, looking at what the barriers and facilitators to the use of evidence by policymakers are. And what's really interesting here is that it comes down to quite soft, we might consider quite soft skills. It's about relationships. It's about contacts, having conversations, and it's about generating trust. So just in the last minute, I want to introduce you to a new project that's just started called the Marie Curie Better End of Life Care Programme. So this is a 3-year programme of work funded by Marie Curie. It's led by us at King's in collaboration with Fliss Murta from Hull and Stephen Barclay from the University of Cambridge. The aim of this project is very high level. It's to understand what it's like to die in the United Kingdom and to frame that evidence in a way that compels policymakers to take action. I don't have time to tell you about any of the data in our first report, which came out in April. You can download it using the QR code there if you would like to see it. I guess why I wanted to just introduce this project to you is that even though it's only been up and running for a few months, we've already learned a huge amount about actually how we engage policymakers with our research. And one of the most important things I've learned is that we as academics, or even as clinical academics, we cannot do this alone. Working with the voluntary sector, with our colleagues in policy sectors, and with patients and carers is absolutely essential to ensure that the research that we do ends up having an impact on patients and carers. So how can we bridge the evidence policy gap? First, we need to understand and address policy priorities. We need to frame our research in a way that speaks to these priorities, and we need to embrace and grow our cross-sector collaborations. Thank you very much for listening.
Thank you very much indeed, Katherine, for a fantastic and inspiring talk. Please, can I remind people to put their questions, and I'm sure plenty of people have got questions. If they can put them in the chat, that would be great. And I've got several questions that I'm interested in asking. The first one, which I thought was really interesting, is how you said that the policymakers respond to individual stories and things that bring the reality of the experience to life for them. And I was thinking about how you can go about incorporating those stories and conversations whilst sort of maintaining the academic rigor of the research. How do you think it's most effective to combine the two?
Yeah, so this is something I'm just beginning to learn because I'm a data person. I like numbers and statistics and confidence intervals. But actually what I've learned a lot through working with policymakers over recent years is those things don't really carry as much weight as we might think, and we need to draw on other resources. So the Marie Curie Better End of Life report, I think, is a really good example where we've got statistics in there, we've got graphs, we've got tables, but we also draw on patient stories to really make those graph statistics and tables come alive. What was very valuable about working with a big charity to produce that report is that it wasn't just about the single product, the single output. Actually, there was a lot of supporting work and supporting outputs, like stories pitched to the newspapers, like patient surveys and vox pops type work to find out what the public thought, to really drive home those policy messages.